Hi, welcome back to Rohrich Knows Podcast, helping you become a better you. And we're especially privileged today to have Dr. Ed Rodriguez, the chair of plastic surgery at NYU, with us today. Ed, welcome.
Hey, Rod, how are you? Good to be here with you.
It's great. Great to have you with us. We're going to talk about a fascinating topic, face transplants. And really, Eddie, you're really the world expert today on face transplants. And really, we're going to talk a little bit about how you got to this level, but also one of your amazing patients. And I saw this in the New York Post. I think he's 3 years post-out. He had a double hand and full face transplant, and he's in love. That's amazing? So
it's always such a gratifying feeling to see these patients do well.
Yeah. So tell me a little bit about, before we talk about him, tell me a little bit about how did you ever get interested in facial transplantation? I mean, obviously, Dr. Rodriguez is a world-famous craniofacial surgeon, and he's a highly skilled, and he heads the team that does all these transplants. So I know you trained at Hopkins. So how did you get interested in face transplants?
Yeah, it's a great story, and I'll try to summarize it for you and your viewers. But everything began back in Hopkins, I would say probably 2001, when we have one of our esteemed colleagues by the name of Maria Simonov, who was the first American surgeon to perform their first face transplant in the U.S. And she presented some of the work on her rat studies of performing some of the face transplants. At that point, it wasn't even a clinical reality. Right. And my main mentor, Paul Manson, who you know very well, and he respects you greatly, he goes to me, Eddie, this is the kind of stuff you should be doing in the future. And I thought about it, but it really didn't capture my mind. But if we kind of move the clock forward, part of our rotation in Maryland is to be involved in shock trauma. And, we dealt with a lot of horrific casualties related to motor vehicle accidents or ballistic injury burns. And then I went on to Taiwan to do some fellowship with kind of one of our premier esteemed colleagues in microsurgery by the name of Fu Chan Wei. And when I was abroad, Rod, we were in the midst of wars in Iraq and Afghanistan. I finished my fellowship, and when I came back to the U.S., a good portion of my job was at shock trauma. And Paul Manson was being asked by Walter Reed Army Medical Center and National Bethesda, one was the Army and one was the Navy, to assist with these casualties. And he said, well, I got something better. I'm going to send my young protege. And I started seeing these injuries, and they were devastating. We hadn't seen anything like this probably since World War II with trench warfare, because these improvised explosive devices were highly explosive mechanisms, were, just taking off limbs, but leading to horrific facial injury. Because the soldiers, they had a helmet, but their face was exposed. So you had a lot of tissue loss around the mouth, around the eyelids, the nose, very difficult areas. And despite all the levels of sophistication in conventional surgery and even in microsurgery, the quality of our results really were suboptimal.
Right, that's amazing. And of course, because of the armor and technology, they were living, because in the past they wouldn't live, right? So
and if you look at all the wars that we've been at, the survival of our soldiers through Iraq and Afghanistan has been the highest it's ever been, because exactly what you're reflecting on, the protective armor.
Good.
So then, we put together a grant through the Office of Naval Research, and there were a number of different enterprises that were putting grants for lightweight armor, a variety of different things. And we put together a grant which was entitled Face Transplant for the Wounded Warrior. And that gained some support for initial clinical basic science research to move towards clinical face transplant.
Wow. So
and that's kind of where it began, kind of at the bench, and then we took it to the bedside.
Yeah. So when did you do the first face transplant? I mean, when did you do that?
The first face transplant was in March of 2012 on Richard Lee Norris, which was a patient that I had cared for many years, and actually was referred to us from another state and had multiple surgeries prior to arriving to us. And he had the typical deformity that I consider is basically untreatable. No nose, no lips, loss of the lower jaw, loss of the upper jaw, cheeks were compromised, missing tongue, a lot of injuries, and he was kind of dependent on a tracheostomy for breathing and on a feeding tube to supplement his nutrition. So pretty bad injury.
And that was done at NYU?
No, that was the first one. I did that at Baltimore at the Shock Trauma Center. That was the first face transplant I did, which encompassed all the tissue from the top of the head, forehead, eyelids, nose, upper lower lips, chin, skin of the neck, in front of the ears.
Wow.
And then inside, the reason it was pretty comprehensive is that I included the upper maxilla, so the upper jaw with 16 teeth and the palate, and then the mandible with 16 teeth, the floor of the mouth, and the anterior 2/3 of the tongue. And we did that all as one unit with soft tissue, skeleton, and all the motor nerves, tongue, everything came together as one unit.
Yeah. Now, what Dr. Rodriguez is talking about is an amazingly complex procedure, and you just can't go to the operating room and do it. I mean, how long did you prep your team, and how big was your team when you did that?
Right, and that's an important question, Rod. This is not just something that, like what we normally do in our typical practice is that we identify an issue and we're ready to go to the operating room. This is an operation that you really have to rehearse multiple times. We practice in a typical tissue lab, a recipient and donor operation. We practice simultaneously, and we probably did that for about 15 times.
Wow.
And we translate that from the tissue lab into the operating room, where we just practice in the operating room setting with our nursing staff. We practice with all the instrumentation, figure out what we need to do. Because I think what most of the viewers need to consider, when you're performing a face transplant, you have to keep in mind that there are other individuals that require life-saving organs. And in Richard Lee Norris's case, not only was a face procured for Richard, but heart, 2 lungs, 2 kidneys, liver, pancreas, all these organs, simultaneously went to other patients. So you have to be able to orchestrate that, so these life-saving operations are also successful. So we practice many times to ensure that we know exactly what to do. And we do it so many times, Rod, that we just do it automatically. We can do it in our sleep. And we know that once we identify the ideal donor, which is an important element, that we are ready to go and we will drop everything and go do this operation.
Wow. So how long did that first one take?
The first one, since I had never done it, took me 36 hours.
Wow.
36 hours straight.
And you were there the whole time?
Absolutely.
I know.
Absolutely.
See, this is the difference. I mean, you're the team leader, but leaders lead by leading. Yeah, that's why it was successful.
Yeah, you can't break away from this. And I often tell people, like, how do you have the strength to do it? And I often say, well, for all the mothers in the world, no one ever questioned how long do you have to stay awake to care for your sick child. So when you're caring for an individual and a family whose life is completely dependent on us, we can't stop until we get that patient safely to the recovery room.
Yeah, amazing. So fast forward, then you went to NYU as a chair, and then how many transplants have you done at NYU?
At NYU, the recent one, which I will barely mention,
okay,
but it's not public.
I won't.
We'll have done 4.
4? Wow.
4 at NYU.
And all of them are really historic ones and different ones. So let's talk about this gentleman that was in the New York Post, because that's certainly, and that was groundbreaking, unique, published in the journal. So tell us about that. And there's a young guy, he had a bad motor vehicle accident, right?
Absolutely. So this is, his name is public, so I can mention him. Joe DeMeo is a wonderful kid. A very nice Italian family from New Jersey. Joe's incredibly hardworking, and he loved his work, and his employers, they're a wonderful family. And he normally worked the day shift, and occasionally he worked the night shift. But when he did the night shift, when he was asked to do it, he often would get some rest and do it. So this day was a little bit unusual because he was out, he had the day off, so he was out with his father actually playing golf. Out all day, having a great time with his father, and then later that evening got called if he would be willing to cover the night shift, which he did. Unfortunately, driving home, he fell asleep on the vehicle and flipped the car, and probably what's considered one of the more dangerous interstates in New Jersey, but not just New Jersey, but for the whole country. When we looked at the research, it's a very dangerous highway. So he flipped the vehicle and was trapped he was restrained with the cross strap and the waist belt. And a wonderful Good Samaritan jumped the highway and actually released the seatbelt, saved them, and the car immediately exploded. But, you know, he had already sustained over 80% total body surface area, 3rd-degree burns. So he was badly, badly burnt.
That's amazing he even survived.
Absolutely. And Rod, you and I know that patients that have that amount of burn, inhalational injury, lung injury,
right.
But he didn't have any of that. You know, he was meant to survive, but he did lose his face. You know, he lost his eyelids, lips, and his arms were completely scarred and burned.
Wow.
He survived. He was in the hospital for quite some time and underwent many surgical procedures, skin grafting to get him better. But the worst thing for Joe, the patient, was that he lost all of his independence. His mother had to feed him. His mother had to bathe him. His mother had to dress him. And this was a kid that already had plans to have his own apartment, was set to go, really had big aspirations, and that was absolutely destroyed. So when he came to me, you know, we talked about face, but for him, the most important thing was to have his hands, because with his hands, he could have independence, right, and he could thrive again. Now, it's important that your viewers know that there have been 2 separate attempts in the world to do a face in bilateral hands. One was attempted in Paris by a good colleague of yours and mine, Laurent Lantieri, and the other one was attempted by the group at Brigham and Women's. And the first patient who underwent face and bilateral hand unfortunately died from infectious complications within 30 days of the surgical procedure. And the second patient in Boston, although survived, lost the hands within several days.
Yeah.
So there was really no proven track record that this can even be successfully performed. But I felt that there should be no rational explanation why this should fail. So it kind of allowed us to really think about the process a little bit better. And I did change things a bit. And I think it's important, you being one of the best editors of our premier journal, sharing information, we're able to learn a lot from each other. And I think one of the reasons why our team was successful is learning from what these other groups as pioneers took on. So we learned from their experiences.
Yep. And so how long after his injury did you do this procedure?
We did his injury probably close to 2 years afterwards.
That's amazing. And then how long did this procedure take?
So this one was tricky, just to highlight a few things. He had a very high PRA. PRA kind of defines the antibody level, which means it makes it very hard. We have a narrow window identifying the donor.
Right.
So just to go back, we highlighted when you first asked me, my first operation was 36 hours.
Right.
Then I came to New York, and then I did that operation on the firefighter. That operation, I got it to 25.
Wow.
Always trying to get it down. The third operation I did on Cameron Underwood from California, I got that one to 25. So my goal with Joe was to be able to do a face and 2 arms under 24. And thankfully, I was able to do that in 23 hours. But I have a remarkable team, Rod. And,
oh, I know. I mean, to do that and to do a face transplant and arms, that's unbelievable.
Yeah. It was a very well orchestrated dance. We didn't miss a beat. You know, there's a lot of organizational planning that goes into that. And Joe was right-hand dominant. So the first thing that I wanted to do was you have to amputate his arm that's non-functional. And the first transplant we did was his dominant hand. So we got the right arm on first.
Okay.
The dissection of the right hand on the donor, that took about 6 hours. And then we took that to the recipient room, Joe's room, and we started connecting that. And we do it in a systematic manner where we connect the radius and the ulna. The bones have to be appropriately positioned so that also both arms are at the same length when they're lying by their side in repose. And also the pull of the tendons, whether it's the extensors or the flexors, of which there are 24 of them, have to pull in the same manner functionally. So once the right hand was being attached and connected and we got vascularity, then I gave the green light to remove the left arm on the donor, and reattach the left arm. And then once both arms were doing pretty well, then I went ahead and I usually procure the face on the donor. And by that time, I have green light for what we call all solid organ procurement. So at that point, once I'm about to remove the face, we take out the heart, 2 kidneys, liver, lungs, everything comes out in unison. Those organs all get packaged in coolers, and they go on their way via helicopter or emergent ambulance to their locations, to the appropriate hospital, so that those patients can receive their life-saving organs.
Amazing. Amazing.
Yeah, and that goes, we go into the recipient room and then we finish the operation at 23 hours, it's all done.
That's unbelievable to do all that in 23 hours. That's unbelievable. And now let's fast forward. As in closing, I saw this story and I thought it was remarkable. So now and I think you told me that this is a nurse that he's dating and stuff. So isn't that amazing?
They're a wonderful couple, Rod. They met each other. They've been together. So Joe's dreams have been fulfilled. You know, he lives in an apartment with her. He loves muscle cars. He drives independently. He sends me pictures driving the Pacific Coast Highway in California.
Really?
He's with his girlfriend, and she's a wonderful young lady, and we hired her at NYU. She's one of our OR staff.
Phenomenal. So he's driving and back to doing things?
Driving, he's completely independent. You know, he drives to his appointments from New Jersey to Manhattan. All his, you know, everything that he wanted to do, he's achieved. There's videos of him flipping pizzas. He likes to cook. All the things that he wanted to do, wow, he's able to do. And I'll tell you, there's nothing that brings greater satisfaction and gratification to a surgeon than to see an individual live the life independently that they desire to live.
Yeah, I mean, truly a modern medical miracle, but based upon the incredible, highly skilled group like what Dr. Rohrich is talking about. I mean, it's unique in the world. I mean, what you've done at NYU, and I know all your faculty. So what a team approach. That's unbelievable. So kudos to you.
Thank you.
I mean, that's unparalleled. So what do you see next for face transplants? I mean, obviously, you know, you can't do these in very many places in the world. So what do you see next for face transplants, Eddie? What?
I think the next frontier, when we're dealing with a face, we can transplant tissue. I think the important thing are the nervous elements. And in the face, we deal with the peripheral nervous system. We deal with the sensory, which provides sensation, and we deal with facial motor function that provides movement to the face. I think we're ready to cross into the central nervous system, and I've been preparing for this quite a lot. And as I think about it, it's about transplanting the face with an eyeball. There are plenty of individuals that have lost sight, right, whether it's from our wars, and as we talked about, these improvised explosive devices and these high energy forces of ballistics. What we've seen in a lot of our soldiers, that the injury to one globe, as it injures the eyeball, it injures the optic nerve, and the propagation of energy actually goes all the way to the chiasm, which is where both optic nerves exit.
Right.
And that propagation of injury, now we're beginning to see some consequences in their only remaining globe. So I think one of the important elements is to be able to potentially consider transplanting the eye, and I'm not going to say that we're going to restore vision, but we all know that the globe is like a camera.
Right.
So if we're able to bring the camera back and we're able to retain the vitality of a retina and are able to connect the vasculature of the eye, which is it's the ophthalmic vein, the ophthalmic artery, which come off the internal carotid artery and the cavernous sinus, and connect the optic nerve, we don't know what's going to happen in the central nervous system, but I already have enough proof that it can be done.
Can be done. Wow, man, that's as close to brain transplant as we get so far, right? I mean,
we're getting close. We're getting close, Rod.
It's unbelievable. So, amazing. I must say, this is just totally revolutionary and groundbreaking. I mean, this is Nobel Prize stuff, man. I tell you what. I mean, kudos to you and your team, Eddie. I mean, and it's all, I'm really proud of it as plastic surgeons. So,
thank you.
I mean, please send us your comments and thoughts. This is a wow. a total wow, Eddie. So I cannot thank you enough for taking the time out of your busy practice. I know you're always busy, and I can't wait to see what's next. And
My pleasure. My pleasure. Thank you for having me.
You bet. It's my pleasure to have you with us. Okay, take care. Dr. Ed Rodriguez, Chair of Plastic Surgery at NYU. Phenomenal. Thank you.